And March is Colorectal Cancer Awareness Month, and we're really excited today to have a really comprehensive panel for you guys to really just educate the community around colorectal cancer and your risk factors, screening options, and then if you are unfortunately diagnosed with colorectal cancer, what your treatment options would be. So with that, I will go ahead and I will share my screen and get our presentation up. So just bear with me for one moment, and then I'll go ahead and hand it off to our panel for today's discussion. All right, so like I mentioned, our topic for today is colorectal cancer and just really what you need to know. This discussion is brought to you by AdventHealth's Digestive Health and Surgery Institute, as well as the AdventHealth Cancer Institute. And our topics for today will be just setting the stage for colorectal cancer, your screening options, and then your treatment options if you are diagnosed. So with that, I will turn it over to Dr. Nevine Hanna, a radiation oncologist with AdventHealth.
Thank you so much, John, for inviting me to speak on this very important topic. Now, as we know, colorectal cancer is the second leading cause of cancer-related death in the United States. 1 in every 20 individuals will be predisposed to having and being diagnosed with colorectal cancer. Now, the United States Preventative Services Task Force, or USPSTF, just announced recently that the screening age will go down from 50 to age 45. So at 45 years old is the new age. Now, as we all know, colorectal cancer is preventative and is preventable, so that's a very important thing to know. There are factors I'll be talking about later in the slides of what can we do to help prevent this cancer. One of the things that you should pay attention to are symptoms. So symptoms such as persistent change in bowel habits, if you're having too much diarrhea, constipated outside of the norm, if you're having persistent abdominal pain or discomfort, cramps, if you have bleeding in the stool, and you'll notice that by either streaks of blood in the stool, or you might notice what we call melena, or just bright red blood per rectum, or dark stool. Those are all signs to pay attention to. Unexplained anemia or weight loss are also very important. For example, somebody that just does regular blood work, and all of a sudden they found that their hemoglobin has gone from a 10 to a 6 without any explainable reason. That's something to pay attention to that can point to having colorectal cancer. So even primary care screening is extremely important in that sense. Now, what are the modifiable risk factors and what are the non-modifiable risk factors? Non-modifiable risk factors, stuff we can't do anything about. For example, somebody's age, the African American race, which is more predisposed to having colorectal cancer, anybody with a personal or family history of colorectal cancer or polyps, individuals with inflammatory bowel disease and inherited syndromes such as Lynch syndrome and other syndromes that have colorectal cancers as one of the presenting cancers in that cohort. What are risk factors that are modifiable, things that I can go home and change to help me be less predisposed to having colorectal cancers? That would include a low fiber, high fat diet, sedentary lifestyle, diabetes, obesity, smoking, and heavy alcohol use. If we can prevent all of these by eating a good high fiber diet, less low in fat, if we're more active, if we can prevent obesity, which predisposes to diabetes, less smoking, less alcohol, then you're doing your part to prevent colorectal cancer.
So thank you, Dr. Hanna. Sounds like there's a lot of things that we can and can't do to kind of to mitigate our risk for colorectal cancer, but the next step in that would be then to go and get screened. So next, we're going to hand it off to Dr. Mihir Patel, a gastroenterologist with AdventHealth Medical Group, to talk through our screening options for colorectal cancer.
Thank you very much for allowing me to discuss on this very important topic. So the colon cancer screening is very important. The colorectal cancer is more than 90% curable if it's diagnosed in its early stage. So to catch this problem at early stage, we need to consider going through colon cancer screening. There are several options available now, and they are divided into two major categories. One is direct visualization tests, and two, the stool tests. In terms of direct visualization tests, the most widely used is colonoscopy. There are some options such as sigmoidoscopy or a specialized CT scan called CT colonography, but they are not widely used because of certain limitations and issues related to those tests. So during colonoscopy, which is the most commonly used method or modality for colon cancer screening, we pass small tube, which has camera on its end, from anal opening and to look inside the colon. During procedure, person receives certain medication to make them very comfortable, and most of the patients don't feel or remember any part of it. Also, risk of procedure is very low as well. There were need for bowel preparation day before the procedure, but the options of bowel preparation are much more and better compared to what it used to be available in the past. And during colonoscopy, if somebody are not found to have precancerous polyps or actual cancer, then they were to need the next colonoscopy in 10 years. In terms of other categories of stool tests, there are two approved tests, which are stool occult blood test called FIT test, and stool DNA test called Cologuard. And in terms of stool blood test called FIT test, if somebody is found to be positive, then they proceed with colonoscopy as next step. And if they found to be negative for that test, then patient can get the annual stool FIT test for colon cancer screening. If somebody chooses for stool DNA test called Cologuard, and if they found to be positive, then again they proceed with colonoscopy as next step. If they found to be negative, then they are recommended to receive the follow-up stool DNA test or Cologuard within 3 years. However, it is very important to understand which patients are not a good candidate to choose stool-based tests. If patients are with symptoms such as blood in the stool, weight loss, and some of the similar symptoms, if somebody has family history of colon cancer, if somebody themselves found to have colon polyp in the past, or certain condition which makes them at high risk for colon cancer, then it is not appropriate to choose the stool-based tests for colon cancer screening. And instead, it is important for those people or patients to proceed with colonoscopy as optimal modality for colon cancer screening. I hope this information is helpful. Thank you.
Thank you, Dr. Patel. Definitely lots of screening options for patients out there, so really no excuse to not get screened for colorectal cancer. And so with that, if you are screened and found to have a colon cancer, your next step would then be to get obviously treated for colorectal cancer. So we are going to now hand it over to Dr. Johnathan Lucking, a colorectal surgeon with AdventHealth Medical Group, to talk through surgery for colon and rectal cancers.
Thank you for the opportunity to discuss this. So if you made it to me, you've probably already been diagnosed or have the suspicion of having a precancerous or cancerous polyp that needs to be removed. The first step when you see me is basically to figure out what it is, how advanced it is, and how we're going to take care of it. We do that, first of all, with the diagnosis via colonoscopy and sigmoidoscopy that may be done by myself or my colleague, Dr. Patel, a GI doctor. Sometimes it needs to be repeated based on the pathology. Once we have the diagnosis of cancer, the next step is to figure out how advanced or how progressed the cancer is. And we do that with several modalities. This is what we call staging. And staging is important in terms of prognosis and treatment. So we start by getting CT scans of the chest, abdomen, and pelvis. The goal of these scans is to look to make sure that the disease has not spread through any other lymph nodes or any other organs in the body. It also gives us a sense of where the tumor is located. If there's concern that this is a rectal cancer, lower part of the colon or the most distal part of the colon, patients will go for an MRI. This tells us a lot more about the tumor and more detail about the tumor than the CT scans are capable of. There are some things that will prevent you from having an MRI, i.e. an implanted pacemaker or defibrillator, but in that case, we get an ultrasound to get farther staging on that. A PET scan, a scan to look at the metabolic activity throughout the body, is usually not used as part of the initial scanning for colorectal cancer. And in addition, we get a full set of blood work looking at a CBC and CMP to prepare you for surgery or your treatment, and a CEA, which is a specific marker for cancer, which can be used later on to assess your response to treatment. The next step is to actually come up with a plan. And that's where we discuss this at our multidisciplinary tumor boards. These involve both your surgical provider, your oncologist, and a radiation oncologist to discuss the next best steps in your treatment. Depending on the stage, depending on whether it's a colon or a rectal cancer, you may go for chemotherapy or radiation prior to surgery. However, most colon cancers are treated with surgery to start. And then based on the pathology, we move on to chemo and radiation later on. Yeah. So what are these stages and treatment options? So colon cancer and rectal cancer are staged and treated slightly differently. For colon cancer, our colon cancer is stage 1 through 4, based on how far the tumor has spread or how far the cancer has spread. Stages 1 through 3 basically involve the colon and the blood supply providing, or the blood supply that supplies that part of the colon. These go straight to surgery, which we'll talk about later. Stage 4 disease, meaning the disease is spread to another organ, requires chemotherapy or some other systemic treatment first. Rectal cancer is a little bit different based on where it's located in the patient's anatomy. Stage 1 is the only stage that we take straight to surgery. These are very early localized tumors. Stage 2 and 3, where there's been some more spread of the tumor, those should have chemotherapy and radiation prior, which improves the outcomes of our surgery. And again, in this case, stage 4 disease or disease that has spread elsewhere gets treated with chemotherapy up front. So the treatment options, as we briefly touched on, are upfront surgery. The goal of this is to remove all of the tumor and obtain clear margins, meaning that we get the tumor out and we have nice healthy tissue between, and get rid of the lymph nodes. And these lymph nodes, getting rid of them gives us both staging information and prognosis information, as well as getting rid of extra tumor. Neoadjuvant therapy is therapy prior to surgery. This is particularly important in our stage 2 and stage 3 rectal cancer and some stage 3 colon cancers. And this is either going to be chemotherapy or a combination of chemotherapy and radiotherapy prior to surgery. The goal of this, again, is to shrink the tumor and make our surgery more successful at removing the cancer cells. And then finally, after you've had surgery, is adjuvant therapy. This would be chemotherapy to help get rid of whatever disease may be left or disease that recurs after the prior surgery. Your surgical options nowadays are many. And again, it'll depend on what type of cancer you're diagnosed with, and also whether you've had surgery before or any other issues that may make surgery difficult. So there is the old open surgery, which involves a large midline incision, large enough for us to be able to get the piece of the colon and associated tissue out safely. Nowadays, the more common way and the more frequent way is laparoscopic surgery. This involves several small incisions and blowing the abdomen up like a balloon with CO2 to allow us to work and operate on the colon within the abdomen. This is the preferred way nowadays for us to do surgery because it has better patient outcomes, less pain, shorter hospital stay, and has equal oncologic outcomes, meaning we're able to remove the tumor as successfully as we are with open surgery. And a newer technique, robotic surgery, is kind of a advanced laparoscopic or advanced minimally invasive procedure. It allows us to use a robot, which gives the surgeon and the patient some advantages to remove the tumor. And finally, transanal surgery. This is a surgery usually done by a colorectal specialist and most useful for those early stage rectal cancers. These are short, either outpatient or short hospital stay surgeries, and can be curative in some cases, or can lead us to make better decisions about future therapy or treatment. Survival rates for colorectal cancer can be very good if they're caught early enough. Ideally, the best thing is to catch it before it's even an invasive cancer and needs to see me, which would be done through your screening colonoscopy or diagnostic colonoscopy. But patients who have stage 1 through stage 3 colorectal or rectal cancer can have survival rates greater than 70% over 5 years. However, when it does spread to the other organs and becomes stage 4, the survival rate over 5 years drops precipitously. That's why it's good to catch it early with screening. So again, get screened.
All right. Thank you, Dr. Lucking, and thank you, Dr. Patel and Dr. Hanna, for that great information. I think all of you would agree the big takeaway is just to get screened and catch it early, and really to prevent from even having to hopefully see any of you guys for any sort of follow-up. But if you do, they're here for you guys at AdventHealth. So for those of you watching, I would just encourage you, if you want to get in contact with any of our specialists here at AdventHealth or get screened for colorectal cancer, I'd visit getscreenedtoday.com to learn more, or visit the link in the description of this video. Thank you all for watching.